everyone, and good morning as well. Thank you for joining the Society of Hospital Medicine's Improving End-of-Life Care in the Hospital, Advanced Care Planning as a Quality Improvement Opportunity for Hospitalists. This webinar has been compiled by the Society of Hospital Medicine Center for Hospital Innovation and Improvement, and we are also working with the Hastings Center in developing today's content and content for future resources to inform opportunities for improving end-of-life care in the hospital. Today we have three presenters with us. Mr. Josh Laps is the Government Relations Manager at the Society of Hospital Medicine. Mr. Laps addresses quality and pay for performance programs as they pertain to hospitalists. Dr. Nancy Berlinger is a research scholar who focuses on ethical challenges in healthcare work and on related areas of professional education and health policy in the United States and internationally. Dr. Berlinger directed the research project that produced a revised and expanded edition of the Hastings Center Guidelines for Decisions on Life-Sustaining Treatment and Care Near the End of Life, and is the first author of the new guidelines. And finally, we have Dr. Stephen Pantelot, who is a professor of clinical medicine in the Department of Medicine at the University of California, San Francisco, the Alan Cates and John Bernard Endowed Chair in Palliative Care, and the founding director of the UCSF Palliative Care Program. Dr. Pantelot is also the director of the UCSF Palliative Care Leadership Center that trains teams from hospitals across the country on how to establish palliative care services. Dr. Pantelot is board certified in hospice and palliative medicine and internal medicine. And in 2007, Dr. Pantelot was a Fulbright Senior Scholar studying palliative care at the Royal Prince Alfred Hospital, University of Sydney, and Curtin University in Sydney, Australia. Dr. Pantelot is also a hospitalist and is nationally recognized expert in hospital medicine as well as in palliative medicine. He is a past president and past member of the board of directors and the former chair of the ethics committee for the Society of Hospital Medicine. And we thank all of our guests today for willingly presenting this information to us. And finally, I would like to share with you our disclosure announcement. No commercial support has been accepted related to the development of this activity. As per the faculty and staff conflict of interest forms, there are no relevant relationships to disclose. And so I will ask Dr. Nancy Berlinger to begin our presentation for today.
Thank you, Jenna. I'm delighted to be here today, and I'm delighted and grateful that you're all taking the opportunity at a busy time of the year to talk about an issue that you've probably been hearing a great deal about, the fact that after many years of debate, the Medicare system has undertaken a reform to provide physician reimbursement for end-of-life counseling, a reform that applies both in the primary care setting, but also is potentially a significant issue for hospitals and hospitalists and other hospital clinicians. So our colleagues, Mr. Lapp and Dr. Pantelot, will be talking about other aspects of this reform. Josh will be talking specifically about what this reform means, things like the codes, how it will work when you see it at an operational level. And Dr. Pantelot is going to be talking broadly from his perspective as a palliative care leader about the issue of improving end-of-life care. And I'm going to sort of be in the middle where ethics often is, which is to say, what is this thing called advanced care planning? Why is it part of ethics? Where does it belong in the practice of a physician? And why is it especially an important issue for hospitalists given the patient population that you serve? So we can just advance a slide. I don't have control over my slides today, but and so the reason we're calling this Seizing a Medicare Moment is that's partially the title of a commentary that I did with the president of the Hastings Center several months ago. because we wanted to say, this is not just a little incremental improvement here or a little incremental payment stream. Both of those things are important. This is an opportunity to act on a big societal issue, whether you've read a Tolga One Day's book or your mother has read a Tolga One Day's book and told you have to read it, whether you read the Dying in America report from the Institute of Medicine, whether you read our Hastings Center guidelines, or have been following various blogs talking about this topic, or you've just noticed as a hospital clinician, as a hospitalist, that this is an issue you are facing every day, and yet no one is calling you to the table where the end-of-life care providers are and say, we know this affects you too. And so I'm here to let you know that the Society of Hospital Medicine, together with the Hastings Center, is aiming to respond to the situation you face in the context of our societal push to improve end-of-life care or fix end-of-life care. It's a very complicated problem, but we're so delighted that the Society of Hospital Medicine is stepping up to this challenge. So I'm going to talk a bit about that later. But first I wanted to just, as sort of a placeholder, get through some of how we got to where we are today. So if you could advance the slide, please. Okay, so this is just a little bit about the Hastings Center SHM partnership, which is funded by the Milbank Foundation, which has a longstanding interest in palliative medicine, and the Donahue Foundation, which has a longstanding interest in improving healthcare. So that's just my NASCAR slide, and now we can keep going. Okay, and that's just the Hastings Center guidelines, which I'm going to be making some reference to. We can keep going. Okay, so back in 1987, when the first edition of the Hastings Center Guidelines was formulated in the mid-1980s, this is before the Cruzan decision in 1990 from the Supreme Court, which made a constitutional recognition of the right to refuse medical treatment. It's before a lot of the things that we think of today as part of our end-of-life care landscape, and it was the first set of ethics guidelines for clinicians on end-of-life care, especially on the termination of life-sustaining treatment. So a lot of the things that we use every day, talking about surrogates or talking about decision-making standards, came out of this work. It aimed to go from theory about what is good to do for people nearing the end of life to the practical of how you actually do this if you are the clinician on the spot. Several years later, or I should say several decades later, we undertook to do a revised and expanded edition. Our working group included working hospitalists, and what we aimed to do was look at what was more complex about the contemporary environment, where people weren't just stopping treatment, but they were starting treatment, or they were trying treatment, or there were comorbidities in the picture. It was after the Shivo case, which some of you may recall from 10 years ago, an intense end-of-life care case focusing on a patient who was in a permanent vegetative state that was very politically charged. The new book focuses on decisions about treatment, including chronic treatment, and so is characteristic of the Medicare population in particular, where people very frequently have a number of different chronic conditions. And it added perspectives from the disability community. There's a whole section on children and on systemic reform, which tends to be the language in which we talk about end-of-life care now, not just the patient's rights or the doctor's responsibilities, but the fact that this is a complex system. Next slide, please. So the guidelines, and this is where we really get to the meat for the hospitalist. The guidelines, as we published them several years ago, were written for the hospital clinician, for the hospitalist. We actually talk about hospitalists in the book because you are professionals who care for patients who are typically facing decisions about life-sustaining treatment, including a range of routine treatments, which may be cause a life to be shorter or longer. It's not all high-stakes, high-tech decisions, or who are nearing the end of life. You are part of end-of-life care systems, even if you are not a palliative care professional, a hospice professional, even if you work with medical patients in a step-down unit and a medical surgical unit, because of the patient population you serve. So all hospitalists are part of end-of-life care systems in hospitals and in hospital transitions, and so you need support for this role. Next page, please. So, and this is just to let you know, if you were using the guidelines of the book, to tell you what the section I'm going to be focusing on, which is about using patient preferences to establish goals of care and develop the care plan. Because when you are doing advanced care planning in the hospital setting with an acutely ill patient, you're often not doing it that far in advance. You're dealing with the situation at hand. It's different from the situation of a primary care provider who is talking with maybe a person who has just become eligible for Medicare in some cases about what they might want to record as preferences for future care, but not necessarily based on a diagnosis. You're within a diagnosis and often a prognosis, and decisions are happening in real time. Next slide, please. Is that slide? Oh, here we go. Okay. So our guidelines, this was before, if we can go back, thank you. Okay, so this was before the Medicare reform, but as an ethics position, as a consensus position about good practice, our book recommended advanced care planning, because asking patients about their values and preferences and documenting and using these preferences to guide their care is integral to good healthcare and ethically sound practice. If you do this, you know that you are practicing ethically. You are honoring patient preferences, you are honoring patients' rights under the law, you are providing a sound process within your organization in terms of avoiding confusion and doubt for the next hospitalist or the next nurse who is taking over from you. There isn't going to be this conflict over, oh, what does the patient want, because you have done those things. It doesn't mean all conflict at the end of life, all distress at the end of life will go away, because this is typically a distressing time in a person's life and in the life of the family, but you have undertaken certain steps to mitigate some of these common problems. Next slide, please. Okay, so what do we mean when we say advanced care planning? Despite the name, it's not the same as advanced directives. Advanced directives are forms. They are the types of forms that you might use to record a treatment preference or to say who you want to make decisions on your behalf. And some of them are very, very specific. We have living wills, DNRs, which are about a specific procedure. Those are some names of different types of advanced directives. Advanced care planning is a process of discussion that has 3 goals, and these goals come from one of the innovators of advanced care planning at the American Bar Association. To elicit a patient's values and preferences concerning future treatment, or maybe quite near future treatment, and record the patient's treatment preferences. So this isn't every value that a person has in their whole life. It's about their medical treatment. That's why you as a doctor are involved in this. And then to record it so this isn't a mystery, to make sure that it's in the record. Second is to use a patient's values and preferences to establish goals of future care, to work with the fact that you've had this discussion to talk about the goals, often in light of a diagnosis, a prognosis, and treatment options. So if a person is saying to you, my goal is to not be in the hospital very often, that may inform the actual plan of care for this person. But you're going to have to discuss, given what their diagnosis and their prognosis is how doable is their goal, how feasible is this? But it's very, very interactive, discussion-oriented, whether you're talking with a patient or whether you're talking with the patient surrogate if the patient is unable to have this conversation, or often you're doing it together because a patient has an interest in their surrogate being well informed. And the third is to develop a future care plan that reflects a patient's preferences and goals, and to modify the care plan so it remains consistent with changes in goals. And the reason that this is important is you want to get those preferences into the care plan so it's clear that they came from the patient, because that patient may subsequently lose the ability to tell you about what they want. So you now are very, very clear on the fact that if the patient is unable to make a decision or tell you about a preference, it has been recorded, and a surrogate, the patient's spouse or adult child, may be looking for some evidence of what the patient wanted if they never discussed this. That it happens frequently. And so that there has been research that has come out of NIH that has found that surrogates, being a surrogate is stressful, but if the patient had the opportunity to record a preference, that helps the surrogate feel confident that they are acting in a way that the patient would have wanted. It helps them discharge the obligations of being a surrogate. And it certainly helps if you are making a decision that either the patient didn't have a preference about or the surrogate does not have a lot of insight into. You can look at the overall trend of what the patient was telling you to say, what would this person want? And those are very tough situations. So that's what you're doing when you're doing advanced care planning. Next slide, please. Okay, these are just a few key points about advanced directives, which may be part of an advanced care planning process. They document a patient's preferences. They're authorized by law, describes a couple of different kinds, proxy directives and treatment directives. But it's not the same thing as an advanced care planning process. And we never want to reduce things to just filling out forms. Sometimes you also may be working with a patient who has an objection for some reason to forms. Sometimes a person who is low literate, for example, low literacy, does not feel comfortable with paperwork. But you still want a way to talk about their preferences so that you can record them. So just try to avoid, even though documents are important, they're certainly not the only thing, and they're not a substitute for a true discussion. Next slide, please. Care planning. This is very familiar to those of you who especially probably work in care transitions, but just to review a few points about what we mean when we talk about the relationship between advanced care planning, advanced care planning and a care plan. You're encouraging patients to appoint or designate a surrogate, encouraging the patient to discuss preferences, giving the patient opportunities to review and update their advanced directives. That may be more of a primary care situation, but if a patient brings advanced directives with them to hospitalization, you may well be talking with them about advanced directives that they have created at another point. If a patient is seriously ill, you might be using portable medical orders, which are a specific kind of documentation authorized in some states as POLST or MOLST. You will, of course, be training your staff or people who are working with you in how to use advanced directives and portable medical orders. So this may be at a unit level or at some other level to make sure that people understand what they're doing when they're doing these things. So that's part of the work that the Hastings Center and SHM are doing together. Advance, please. So what we're doing together as our project, the name Improving End-of-Life Care in the Hospital would suggest, is trying to strengthen both clinical practice at the bedside and the unit level and hospital systems at that upstream level. What we're working from as a premise is that hospitalists and other frontline clinicians are integral to good care and end-of-life care in the hospital. This isn't something that can just be done by a palliative care specialist here or a good communicator in the ICU there. It has to involve the frontline workforce. Hospitalists need primary palliative care skills that have recently been articulated, including training, mentoring, and support in conducting goals of care discussions, because discussions about goals of care, as you've just seen, are integral to what we're talking about when we say advanced care planning. You have to talk about what the goals of the care are that follow from the patient's preferences as well as the patient's diagnosis. We will be creating a resource room that is being co-developed by an SHM expert panel together with me and my colleagues to feature a clinical pathway for goals of care discussions initiated by hospitalists. We're hard at work on this right now. We've been doing a lot of really interesting background work this year, and we are now just turning toward developing content for the resource room. And so for the near term, with the fact that this Medicare reform is coming online in just a few weeks, the reimbursement is an opportunity for clinicians and hospital leaders to focus on integrating and improving advanced care planning in the context of acute illness, when a care plan is always needed and a decision may be at hand. So even in advance of the launch of the resource room, this is going to be something that you are going to be hearing about in your hospitals. People may be looking to you to solve the problem or figure out how those reimbursements can be used, and that's why the detailed information about the codes is important. But it is very important that there be integrity to the process that you're using. And so I hope I've very quickly outlined what the consensus is about what advanced care planning is when a patient is acutely ill, and Dr. Pantalot will have many fine insights about how that really can be infused into the practice of hospital medicine. But for now, I think I'm at the end of my slides. I think so. And so, yes. So I will turn this over to Josh unless there are any immediate questions.
So I think we're going to save Q&A for the end of the presentation. But thank you so much, Nancy. And actually, that was a perfect segue into what I'd like to share with everyone today, and that's the policy perspectives on advanced care planning. And as Nancy alluded to, the new advanced care planning codes that are going live with Medicare on January 1st of 2016. So a little bit of background about me. I work in SHM's Government Relations Department, and in that role I have been doing a lot of work around these advanced care planning codes and legislation around advanced care planning to try and push to get this these important codes added to Medicare. Next slide, please. So as many of you may remember, sort of looking back at some of the history of the policy, advanced care planning was actually included in one of the drafts of the Affordable Care Act, or the ACA. Specifically, it was Section 1233 of HR, that's the House Resolution Bill 3200. And so this legislation that was kind of the start of this section was introduced by Earl Blumenauer, who's a representative from Oregon, and Charles Bustani, who's a representative from Louisiana. And as you can see, it was a fairly bipartisan project at the time. And what the section of the Affordable Care Act do would be to authorize payment for voluntary counseling for advanced care planning. However, as many of you may remember, and much to, I think, the chagrin of a lot of folks in the healthcare community, advanced care planning became heavily politicized as a death panel, and so it became a sort of political issue as opposed to a patient care or improving end-of-life care issue. And so because of that politicization, advanced care planning was ultimately stripped from the ACA and was really deemed too toxic for health reform. Next slide, please. So Representative Earl Blumenauer, immediately following the passage of the Affordable Care Act, wanted to resurrect advanced care planning, and he did so with his legislation, the Personalize Your Care Act. And he introduced it in the 111th, 112th, and 113 Congresses. This is a pretty typical thing with bills in Congress these days, is that they need to be introduced multiple times before they gain any traction. The Personalize Your Care Act would authorize payment for advanced care planning, and would also do a number of other things that would kind of round out just paying for the services. So it provide grants for statewide PULSE, or physician orders for life-sustaining treatment programs. It would ensure that any sort of advanced care plans would be portable or obeyed across state lines. And because of the work of Earl Blumenauer, SHM partnered with his office very early on as he was pushing to get support amongst Congress for the legislation in each of the three most recent Congresses, through comment letters, through grassroots activities, through many of you I recognize on the call have taken action in support of the Personalize Your Care Act. So he became sort of the champion of end-of-life care and advanced care planning in Congress. Next slide, please. So for a little bit of perspective from the policy world of why hospitalists care about advanced care planning, hospitalists are inpatient primary care physicians broadly, They're treating acutely ill patients, and many of those patients are also terminally ill. So from CDC data from 2005, and we know this hasn't changed too much, about 50% of deaths occur in the hospital setting. That's a little morbid, but it also indicates the important need for advanced care planning in the hospital. Many patients that hospitalists are seeing don't have an advanced care plan. In part, it's difficult to have this conversation, and there's a lot of confusion amongst providers over who should be having these conversations. There's also, prior to recent Medicare rule changes, a lack of a financial or resource value attributed to advanced care planning. So in previous years, advanced care planning was really a piecemeal sort of enterprise as needed, or by palliative care specialists and other providers who are really champions in their hospitals and local areas for advanced care planning. And then finally, there are issues around access to existing advanced care plans. As many of you are very familiar with, there are a lot of issues around the interoperability of electronic health records and meaningful use. And so this is a sort of impediment towards sharing advanced care plans across settings between outpatient primary care providers and the inpatient settings. And then issues in terms of access to outpatient primary care physicians, and issues in terms of the needs of an inpatient setting and the time constraints of care in an inpatient setting not matching up quite well with outpatient primary care practices. And so for hospitalists and for SHM's perspective, the hospitalists are really confronting issues of end-of-life care and advanced care planning in real time, and much of that is for patients in crisis. Next slide, please. So in 2014, there was a proposal outside of the legislative efforts of Representative Blumenauer by the Illinois State Medical Society to the AMA's CPT, Common Procedural Terminology Editorial Panel. The CPT panel is the AMA's review board and a creation board for all of the CPT codes that are billed by physicians and all providers. So the Illinois State Medical Society advocated for the creation of two new codes around advanced care planning, 99497 and 99498. These were created and released in August of 2014, and according to Medicare, or according to the AMA, excuse me, they would be available for use by January 1st, 2015. Although the AMA had indicated they were available for use, in order for Medicare to reimburse for them, it had to go through Medicare's rulemaking processes. Next slide. So to give you a little bit of background around what is in the advanced care planning codes, 99497 and 99498 are sort of joint codes. 99497 is the first 30 minutes of advanced care planning, and there are no real restrictions as to what that looks like. It could include discussion of an advanced directive or the filling out of any sort of forms. But really the point of the code is to have face-to-face interaction between the physician and the patient, family, and or surrogate. And I should say physician or other qualified health professional. 99498 is an add-on code, which would be an additional 30 minutes to the first code. And the only real restrictions to where and when the codes could be reported are that they can't be reported on the same date as critical care services, intensive care services, or any critical neonatal, newborn, or pediatric care services. Next slide, please. So in the 2015 Medicare Physician Fee Schedule, this is the yearly regulatory process that Medicare goes through to update and make any changes to the Medicare fee schedule for physicians and all for providers, actually. So they considered whether or not to use the codes 99497 and 99498. But because of when the timeline of when the AMA CPT editorial panel put the codes out, it didn't line up exactly to be able to have a notice and comment period for Medicare. So when they were available to for 2015, this rule was written in 2014. The CMS indicated that they would be not valid for Medicare's purposes. They indicated that they thought there was another code for reporting or payment of these services. Namely, that would be the services are already provided by standard E&M coding. And really the rationale behind this was that, in part, we believe, due to the politicization of advanced care planning, Medicare wanted to go through notice and comment. They wanted public comment, public feedback on the use of the codes before they would implement them as payable by Medicare. Next slide, please. So then in the 2016 Medicare physician fee schedule, which was a rule that was written earlier this year, Medicare did have the opportunity and presented for public comment codes 99497 and 99498. After going through the public comment period, Medicare finalized these codes with a status indicator of A, which means that this is an active code which is now payable under the Medicare physician fee schedule, or for the purposes of providers, it is now a billable code beginning January 1st, 2016. And we'll note, and in SHM's comments on the advanced care planning codes, that Medicare declined to make a national coverage determination, which would create a universal benchmark for the nation around how and when the codes would be used and how they're billable. Medicare indicated that their local contractors would be available to make local coverage determinations. Now, this is important because we believe that this will lead to some discrepancies across Medicare contractors or differences across Medicare contractors for how they'll be viewing these codes as available to report. So some of that kind of differences around local coverage determinations could present some challenges as providers are attempting to report these codes. Next slide, please. Within the rule, and this is a question that we faced from our membership and also wanted to make sure was available and written kind of into the rules around these codes, whether or not these codes could be billed in the inpatient setting. SHM had taken the position that the codes should be billable by the inpatient setting. They should be billable across settings and by a multitude of different providers who are going to help and see patients at different points in time in their care. So Medicare, in the formal finalized rule for the 2016 physician fee schedule, indicated that the codes are billable across a variety of settings and depending on the condition of the patient, and that they're billable in a facility or non-facility setting, and by no limitation on what sort of specialty is able to bill this. So this is kind of a broad stamp of approval from Medicare that the codes are meant to be available across settings and across providers. Next slide, please. And then, so finally, to kind of round out some hospitalist perspectives on where we're at today in the context of having these codes be approved for use in the Medicare program. So hospitals have been actively supporting advanced care planning through the Personalize Your Care Act. That's Representative Blumenauer's legislation. And we've been doing so through congressional meetings, grassroots outreach. But we believe even in the context of having these codes available, some of the aspects of the Personalize Your Care Act are still needed. So some of the kind of broader wraparound services around access and training to advanced care planning are things that we believe are still needed outside of Medicare reimbursing for advanced care plans. And then finally, SHM has been supporting the implementation of the two advanced care planning CPT codes. So throughout the 2015 and 2016 rulemaking cycle, we sent our own letters of support and joined multi-stakeholder letters of support, encouraging CMS to implement the codes, and then really pushed CMS to implement the codes in the final rule here. Next slide, please. So with that, I'll turn it over to Dr. Steve Pantelat, who can talk through his perspectives as a practicing clinician on advanced care planning for hospitalists. Dr. Pantelat?
Thank you very much. It's really a pleasure to be with everyone this morning. I could have the next slide. So this is Willie Sutton. So why do I show Willie Sutton? Willie Sutton, as you can see, was arrested. He was a bank robber. Maybe many of you have heard the story about Willie Sutton. When Willie Sutton was asked why he robs banks, he said, well, that's where the money is. And when I think about why hospitalists need to be engaged in this process, it really is because that's where the money is. So many of the patients that we care for need advanced care planning, have important decisions that need to be made during hospitalization. And therefore, we as hospitalists, as the doctors who care for these patients, really need to be ready, willing, and able to provide and discuss advanced care planning with our patients. Next slide. So this is what it typically looks like for many of our patients here in the ICU. And these are the kinds of decisions that patients need to make. And what we know is when patients end up in this setting, they are often too sick to talk with us. And the goal of advanced care planning is, one, to avoid this situation if patients, in fact, don't want to end up this way. And two, if they do end up this way, so that we and their families know what their preferences are, so that we can make sure that they receive care that's consistent with those preferences, and importantly, so that their families don't feel burdened by making decisions in the absence of information. I think any of us who've had these conversations with families have seen what a difference it makes when the family feels like they really understand what their loved one wants and they are merely channeling their loved one as opposed to taking all the responsibility themselves. It can make a tremendous difference in the experience that families have. And the challenge, of course, is that medical care for people near the end of life is really of poor value. We spend a tremendous amount of money. 25% of Medicare spending is for the 5% of people who die each year. And we might say that's really outrageous, and in some ways it is, but in some ways it's not. I mean, where are we going to spend our money if not on the people who are sickest? And most of us will be sickest in the year before we die. So the fact that we spend a lot of money in the year before we die, a lot of healthcare dollars, shouldn't be that surprising. The challenge, of course, is that for all the money we spend, the care is really quite poor, which is to say people get care they don't want, from which they will not benefit. So they get chemotherapy in the last 2 weeks of life, for example. They cannot benefit from that. And they fail to receive care that they do want, from which they would benefit. Care to be at home, good pain management, good relief of their shortness of breath. And so we have opposite problems that we are trying to address. And advanced care planning helps patients make those decisions and participate in their care. So next slide. I know what you're thinking. It should have been done as an outpatient. All of us as hospitalists have had that experience. We cannot believe that this patient came to the hospital as sick as they are without their advanced care plan. If you could advance the slide. That's true. It should have been done as an outpatient. Next slide. And is besides the point. Yeah, it should have been done, but if it's not, it's not. And even if it was done, it's something we probably have to do anyway to at least touch base with the patient. So while we should support outpatient advanced care planning, we have to be prepared as hospitalists to do this as well. Next slide, please. And hospitalization typically results from a significant change in status. People were stable, and now they're not stable. And so it's really important that we be prepared to talk to patients about these issues, because things happen while they're hospitalized that result in the need for advanced care planning and makes it very real for patients in a way that it might not be in the outpatient setting. Next slide. So why should we talk with seriously ill patients about preferences? Well, as we heard earlier, it promotes their autonomy. We know that patients actually want to talk with us about these issues, even though it can be hard and make people anxious, doctors and patients included. Patients do want to talk to us and expect us to raise the issue. They are waiting for us to talk about it. We know that discussions increase patient satisfaction. So you might think that patients dislike it, but in fact they feel closer to their doctor and more satisfied with care. And that absent explicit information, patients infer and misunderstand. So patients are looking for clues for what's going on. And if we don't talk explicitly about what's happening, then patients will begin to infer what's happening from the things that we say and will often get it wrong. And they will think that things are better than they are or worse than they are if we don't talk explicitly. Next slide. So when it comes to advanced care planning, if you could advance it, advance the slide. There it is. Just do it. Whoop, sorry, if we can go back. There it is. I would say just do it. That's what we have to do as hospitalists. We have to just get in there and do it. It can be difficult. It does take some time, but we have to commit ourselves to doing advanced care planning. Next slide. But it does beg the question, who needs advanced care planning the most? So yeah, there we go. All inpatients, maybe. I would argue that probably not all inpatients need this. In a paper that we wrote, Wendy Anderson was the first author, looking at this issue, advanced care planning by hospitalists, we suggested that perhaps not every single patient admitted to the hospital needs an advanced care plan, not even every patient admitted to a hospitalist service. A young person with pneumonia, maybe not. And instead, focus on patients with the greatest need. Ask yourself, would I be surprised if this patient died in the next year? That's actually a very useful question. Advanced illness, poor functional status, those are obviously reasons. Someone with class 4 heart failure, advanced COPD, advanced dementia, anyone with poor functional status, and anyone who's had multiple hospitalizations. That's obviously a risk for mortality and an indication of declining functional status and advanced illness. And if we were going to really kind of spend the time to really do a detailed advanced directive, those are the patient populations that we should be thinking about. So what I want to do now is actually share with you some language, recognizing that these conversations are not easy, and yet they're not impossible to do, and we can learn to do them better through practice, and that often what's missing is some language. And I just want to share with you some language that you could use at the bedside, that you could practice and incorporate into your practice. Many of you will be familiar with these or probably use them already, but these are my go-to phrases that I find really helpful. I'm going to start with what I think are the two best questions for understanding patient preferences, if we can advance the slide. The first question I ask is, when you think about the future, what do you hope for? And then when you think about what lies ahead, what worries you the most? Those are really opposite sides of the same coin. What do you hope for are the things you want to have happen, and what worries you the most are the things you don't want to have happen. And by understanding those, we can really help patients achieve what's important to them and avoid the things that they worry about. What you'll notice here is there's nothing here about death or dying or how sick you are or anything like that, but it really gets patients to think about the future, about what lies ahead, which is really what we want to do in advanced care planning, really understand what's important to patients, and then get into a discussion about how specific treatments might help them achieve their goals or not. Next slide. It's important to try and normalize this so patients don't freak out. So I say something like this: I'd like to talk with you about something I discuss with all patients like you with serious illness. And to me, that's a very honest phrase. I may not talk about this with everyone, but I do talk to everyone like you who's seriously ill. And patients can certainly understand that they're in the hospital, they've got cancer, they've got a bowel obstruction, they've got a pneumonia, they are seriously ill, and they can relate to that. So that's to normalize it. Next slide. Although advanced care planning is more than just identifying a surrogate, it's really important to identify a surrogate for the patient. And I find this to be a really nice way to enter the conversation, which is to say, if something were to happen and you couldn't talk to me directly, who should I talk with to help make decisions about your care? And patients can imagine being so sick that they can't talk to us, right? It doesn't have to mean you're dying. It just means you're sick. And then I follow it up with, Have you talked with that person about the kind of care you would want if you were very sick? Have you talked to your wife? Have you talked to your daughter? And then, if they say yes, what did you say? Right? What did you tell them? And if no, what would you say? And pretty quickly you're into their preferences, you're into what's really important to them without really talking about death or dying or bringing up code status or anything else, but really trying to understand what they would say to someone that would guide their care. Having said that, often we do have to talk about code status, and I just want to say one thing about that on the next slide, which is to be very specific and very unbiased in the way we present it. If you die, which is when we code people when they die. If you die, we can try to revive you. I think here we have to be particularly careful in the language that we use. I've heard people say, if your heart stops, we can massage it to get it started. A patient might listen to that and say, well, why wait till I die? Why not massage it right now? That sounds really pleasant. So in the language we use, we can make codes sound so benign that everyone would want them, and we can make them sound so terrible. We'll electrocute your chest, we'll jam a tube down your throat, we'll crack your ribs. Would you like us to do that? Well, no, duh, of course I wouldn't. So rather than bias the conversation, try to be as honest and direct as we can, and even make a specific recommendation to the patient about the utility of a code, but not bias it in our language. The other thing we have to remember is that context matters to patients. These are not decisions that are free from context. And often you have to explain to someone that, hey, if you die, you're sicker than when you started. It's not like it's a reset like your computer. It's not like rebooting and everything works better. It's like things are worse after you code, and you're sicker, and you're in the ICU, and you're typically on a ventilator, and you're not responsive, and things are a lot worse, and you're already pretty sick. And that's if you survive. And we know that in hospital, all comers, survival of a code is about a third of people survive the code, and about a third of them actually leave the hospital. So context matters. So asking, what are the most important things to have in your life? To be with my family, to be at home, to have time with my loved ones, to travel to my hometown. What's important to you? And that, again, I think it's related to this, what do you hope will happen question, which really tries to understand for patients what's important. In a survey, next slide, where this was asked of people in California, these were the most important issues at the end of life. Next slide, or advance. Yep, making sure family not burdened financially by my care. Important or very important to 67% of people. Next. Being comfortable and without pain, 66%. Next. Being at peace spiritually, 61% of people said that was important. Next. Making sure my family's not burdened by tough decisions about my care. That's where advanced care planning comes in. By talking about what's important to you in advance, your family would not be burdened because they would know what you want. And then it would also, if you know now is the time, you could make sure the family's not burdened financially. Our role as hospitalists to make sure they're comfortable and without pain, and to address spiritual issues and get spiritual care involved because it's so important. And you can see they're living as long as possible, important to only 36% of people as the most important thing. So people are valuing things that are different and that are really addressed through palliative care and what we can do as hospitalists at the bedside. Okay, next. Prognosis is obviously also important, and the way I talk about it is by talking about hours to days, days to weeks, weeks to months, or months to a year. Giving these ranges lets people know that prognosis is inherently uncertain. I can't pinpoint it to say, 3 months, 2 weeks, 4 days, and 6 hours, and people don't really expect that, but these ranges actually provide a tremendous amount of information to patients, and we often can speak in these kinds of ranges and give prognostic information that is really meaningful to patients. If we take a step back from all this, so that's how we might discuss it, the language we would use for patients, just to take a step back and think about the population approach to these issues and to palliative care. Next slide. And to really see where hospitalists fit in this. So if you can advance. If you think about intensity of palliative care needs and looking at a population of patients and thinking about the intensity of palliative care needs on the y-axis over time on the x-axis, we can advance the slide. You'll see that advanced care planning really would apply to people with not very intense palliative care needs. In fact, it might apply to a very large population of patients early in the course of illness. It doesn't have to be done by a doctor or nurse, although obviously we are very skilled at doing it and can become very skilled at doing it. But we'll talk more about a systems approach in a moment. Next slide, or just advance. But what we are going to be providing increasingly is primary palliative care, and many of us as hospitalists are already doing this. We are dealing with the symptom issues. We are addressing advanced care planning. We're raising psychosocial and spiritual issues, getting spiritual care consults, talking with the social workers to really address these issues for patients where the issues are such that they are the kinds of things that we as hospitalists need to do as part of our core competency. Next. Some patients, though, will have such intense palliative care needs that they will require specialty palliative care as a consultation, and we will be reaching out to our specialty colleagues, to the interdisciplinary team, to come and help us care for the patients. And then finally, if we advance the slide, we'll see that there will be some patients for whom palliative care will become primary, either because they'll be referred to hospice or they'll be referred to a home palliative care program, and palliative care will become primary. But we can see an important role for hospitals here, both in the advanced care planning, the primary palliative care, and also, for some of us, a role in specialty palliative care as well. Next slide. Which really speaks to a system approach to advanced care planning, to identify candidates through the electronic health record, right? Who needs an advanced care plan? Well, you can do it patient by patient, but we could use the electronic health record to identify these patients and then provide them with information. There are wonderful websites that really prepare patients for the conversation. Prepare for Your Care, developed by my colleague Rebecca Sidori here at UCSF, a free website in English and Spanish that helps guide patients through how to talk about these issues, how to think about their values, and really moves people through the process. ACP Decisions, developed by Angelo Volandis at Harvard, is a wonderful program of videos that really help guide patients and provide standardized information. Respecting Choices is another system for doing this, and the systems aren't that important. I mean, all of these are good, but it does suggest that there is a way that doesn't have to involve an individual provider with an individual patient to give patients background information. And to remember that this is a team activity. Like all of palliative care, it's best done as a team, and so social workers, nurses, case managers, physicians can play a role together. And if you give people information sort of electronically, if you will, by directing them to a website, even in the hospital, and then follow up, you can actually save a lot of time and have conversations that are more meaningful and more effective. And finally, it's a wonderful QI target. We talked about this earlier. Our hospital medicine group has adopted pulsed form completion as a QI project after the palliative care team adopted it and have been working on it for a year. Continues to work on it. Our hospital medicine group has also adopted it. Pulse form completion for people discharged from the hospital who are not full code. So that's one of our QI targets. Next. To remember that words matter. So while I said just do it, you want to do it well. And how do we get better at this? We have to practice. Practice in advance. Which is to say, think about what you're going to say before you go in the room. You know, take a moment, just like you would with a procedure. You wouldn't just rush into a room and do a procedure. You'd really think about which procedure you're going to do, what approach are you going to take, do you have the right equipment, are you really prepared to do it? The same thing is true if you're going to have a code status discussion, an advanced care planning discussion, a family meeting. Really think about, am I prepared? What am I going to say? How am I going to raise the issue? What do I think the prognosis is? Anticipate some of these things. And to practice in real time. I provided you with some words. There may be other words and phrases you hear from other people. Practice them. Put them into use. Observation of experts. If you have a palliative care team or one of your colleagues who's really good at this, watch them. See what they do. See what words they use. See how they talk to patients and how they carry themselves. You can learn a lot by watching people, and then ask people to observe you. There's nothing like observation, even though it's hard and it can be embarrassing. There's nothing better than that for really getting better at this. And those of us who really want to get better do observation. And finally, there's a way to learn this. To take classes in this. Vital Talk is a wonderful organization that provides real-time help through an app as well as training programs. I see we're at the top of the hour, so I'll go quickly here. Next slide. You know, this is what it might have looked like, 100 years ago, and it looks something like this today, obviously a totally different setting, but it's really an opportunity for us as hospitalists to be at the bedside with the patient and share our humanism to discuss these topics that are really important to them. Next slide. And to remember that rather than taking away hope, we can actually encourage hope by talking about these issues. Hope for healing where there is no cure, for comfort in the face of suffering, and for all that can still be despite all that cannot be. So there's a lot of opportunity here for us as hospitalists. And then last, just to wrap up, last slide. Advanced care planning is a vital skill and competency for us as hospitalists. Patients want to talk with us. We need to establish a system approach to advanced care planning. I think if we do it one-off, it'll be very time-consuming and we won't reach everyone who needs it. Focus your efforts on patients most in need. Use better words so we can have the best conversations possible and practice and focus on improvement. And if we do that, we can have these conversations in the way that really will advance patient care and make sure that patients receive the care they want from us and from the healthcare system. Thanks very much.
Thank you, Dr. Cancelot, and thank you to all of our presenters as well as our attendees today. We have time for one question before we conclude today's webinar. Do we have any questions from our audience?
We had 3 come in. I think we can be probably pretty quick with them. There was a question if more than one specialty can provide ACP during the same hospital admission.
So I think this is Josh Laps at SHM. I think, one of the things that we talked about and one of our concerns is that there is a lack of clarity with no national coverage determination around the 2 codes. So there is not a clear sense of exactly how the local Medicare contractors are going to implement the codes exactly. So that's unfortunately I can't give a concrete answer. I don't know if Dr. Cancelot, if you have looked into this or had any conversations with the local Medicare contractors, but there's, in the specific policies, there's nothing to indicate that it wouldn't be acceptable. But again, we expect that there will be some differences depending on Medicare contractors.
It's a great question. If the palliative care team and the hospitalists were both there at a family meeting where we did an advanced care planning conversation, could both physicians bill? I don't know. Obviously, both physicians can bill that day. Whether they can both bill for this, I don't know. I suspect these rules will be developed over time. I don't know. It would be surprising to me if you couldn't bill, more than one doctor couldn't bill over the course of a hospitalization. You could imagine 2 doctors, 3 doctors having legitimate reasons to have an advanced care planning discussion. My question would be more about what happens on the same day and who gets to bill for it, or whether both can. I suspect that will be worked out.
Other questions that came in: is there a minimum time that must be documented to bill for 99497 and 99498, or is a service less than 30 minutes bundled with other services not billed separately?
And I think this would probably be a question, and we can look at potentially looking at some follow-up resources around the codes, and this would probably be a better question suited for folks who are steeped in coding and billing procedures. But according to the policy, 99497 is 30 minutes, and 99498 would be an additional 30 minutes, and the time would be documented in the medical records.
2 other quick questions was around, do we know the reimbursement amount and how often they can be billed?
Again, I think we can look at potentially developing follow-up resources around some of the specifics, but with the codes going live January 1st of 2016, a lot of these very specific things are sort of yet to be finalized, and again with some of our concerns around the local coverage determinations, there may be some differences across the country in how the contractors are handling the actual implementation of the codes.
Okay. One last question from Elizabeth. Is it Namer? Are you there, Elizabeth? I see your hands raised. I have you unmuted.
This is Kim. I was in for Elizabeth.
Okay.
I just want to know, are we going to get a copy of the slides sent to us?
Yes,
yeah,
we will share
we can
slides
provide.
after the presentation.
Okay, great. Thank you.
Great. Well, again, thank you everyone for your time this afternoon, and thank you to our presenters. We look forward to providing a copy of the presentation slides. We also ask you to anticipate the release of resources that we're developing specifically to help hospitalists and other hospital clinicians improve end-of-life care in the hospital that the Hastings Center and the Society of Hospital Medicine will be working on within the next months ahead. Have a great afternoon.